Recording in progress.
I gotta record. All right,
All right.
let me start over. All right, AMT Wade, here we go. You have been dispatched to a bar for a laceration. Upon arrival, you notice several police cars on scene and a man in handcuffs. Law enforcement states that your patient is in the bar and directs you to the back door. You enter the establishment to find a 44-year-old man sitting at a table with a female police officer. The officer tells you he has a cut on his leg. It's not that bad, but we need to check it out so we can document that care was provided. Go for it.
All right. BSI is my scene safe.
Scene is safe.
I got one patient.
Got one patient.
I'm gonna go ahead and call for ALS intercept.
Okay. What type of PPE would you wear to this, you think?
Probably gloves and eye protection.
Okay. All right.
Let's see.
All right. You say you want to do an ALS intercept?
Yes.
Any particular reason why?
Just in case.
So you're gonna.
I don't really see the need. I don't really see the need to do it right then, but might
Okay.
as well have them on.
Remember, you're taking a truck out of status.
Yeah, but if he needs to be transported, I would have to have a transport come.
Come on now, you're an AMT. All right, let's carry on. You'll see why. I'm not starting you off heavy. All right, so press on.
I'm gonna consider C-spine, but I'm not gonna put a collar on because I don't really see the need.
Okay. All right.
I'm trying to remember the scene size of stuff.
Are you on your phone or a computer?
I'm on my computer.
Get your phone out. Pull it up.
I thought you wanted us to do it without it.
No, for the first couple, I'm gonna have you do it with it. That's why I said if you got your skills sheet, you can kill it.
All right.
I'll give you some time. That way we can get the flow of things.
Is it still going to be like the same as the EMT skill sheet?
There's going to be some advanced stuff to it. If you go to, or just go to Google and type in NREMT, AEMT skill sheets, I think it is, or psychomotor evaluation, whatever, it's on there. There's a PDF on there. Hold on. As a matter of fact, let's see if I can pull this up.
All right, I got it.
Okay. There's psychomotor. It says paramedic, but if you scroll down to where it says paramedic, you can hit the tab that says advanced, and it'll pull up all the little PDFs for you for advanced. All right, you ready to rock?
Yeah.
Okay. You mean read anything over, or you think you got it?
Mechanism of injury.
You got cut.
Yep.
So, as you're walking up to the patient is sitting at a table. It appears that he has been fighting. His clothes are disheveled. He is smoking a cigarette. And the student you should immediately at this point do a scene size up and survey the scene. See if you visualize the patient, which we don't have a patient here, so it would be kind of hard to do that, right?
Yep.
Okay.
So my general impression of the patient is
So your general impression of the patient is sick or not sick?
Not sick.
Not sick. Okay. All right. You want to keep going?
Determine the level of consciousness where he would be ANO times 4.
Yeah.
Determine chief complaint of life threat. He has a cut on his leg. I don't see. Is the bleeding like arterial, or is it?
Hold on, I'm looking this. Why is this so hard to read? There we go. All right. The patient is awake and alert, and has extinguished a cigarette. He is upset about what happened and is angry. He repeatedly tells the crew, "I'm not going to the hospital," but he is compliant with all requests from you. Okay.
All right.
All right. So moving on down. I'm not going to use these again. These are terrible. All right, all right, what you got next?
I got the already done the chief complaint. You do the ABC.
All right, you gonna do ABCs?
All right.
So he is alert. All right, when you're looking for airway, what are we looking for?
The patent airway.
Okay, patent and clear airway, right? Open airway. He's talking to you, so you know he's good, right? All right, what's next?
I don't see the need to insert an adjunct for breathing.
Okay, good to go. And why is that?
Because he can maintain his own airway.
Okay. All right, and what's next?
Breathing. I would also take lungs. Lung sounds.
Not yet. Just ABC at this point, remember? Quick. He is breathing because he spoke to you, right?
Yes.
There you go. So when you're in that first initial ABC, it's just real quick, right? We're looking for life threats mainly. Is his breathing adequate? Does he sound like he's exasperated for any reason or anything like that, or does he sound like has any type of difficulties breathing? She's smoking a cigarette and everything else. He doesn't have difficulties now, but he will in the future. And then from there, after you complete your what's the next one? After you complete breathing, what's the next one?
Circulation.
Okay. And what are we looking for right quick?
Just that he has a pulse. But, I mean, he's talking to us, so he has a pulse.
We're checking for any major bleeding, right?
Major bleeding. Signs of shock.
Yeah. Okay. All right. So the bleeding, he does have a cut on his foot, on his leg. It's not that bad. There's a little bit of blood. He should survive it. So right now, what's next? A, B, C, D,
D, E.
D, E. All right. What is D?
I can't even remember. Let's see.
Disability.
Disability. Yeah, see, I never learned all that, like the D part.
And then E is what? Exposure, right?
Yep.
Okay.
Exposure.
All right, so as you're going, the patient's still refusing transport, but states that I'll let you treat me on scene. I'll let you treat me here, but I'm not going.
Well,
So what do you want to do next?
I mean, if he wants to not be treated transferred to the hospital, I cancel my ALS intercept that was coming in the first place. And then what I would do is get him to sign a refusal.
Okay.
But I would make sure that he has. I would treat his laceration first. Make sure he
Okay.
doesn't have any other.
What else are you gonna do?
Obtain his vitals.
Obtain a set. Do the whole gambit. If he's letting you do it, do it. You know what I mean? And then you can be, because this goes back into our documentation. Because then, if any, let me tell you, if you get a refusal and within 24 hours something happens to that patient, it's on you. It's on your licensure within 24 hours. So you got to make sure that you collect all the information you can on that patient in order to confidently be able to sign that refusal. And a lot of time, 9 times out of 10, people sign a refusal, nothing happens. But I can tell you right now, I set an investigation not too long ago where somebody let a patient sign a refusal, and within 1 hour, that patient went back to the house, got out of the car, and dropped dead in the driveway. And that paramedic is no longer operating, and lucky to not be in jail. So that's something you got to think about. It's a pretty serious deal. So make sure you get all your information. So all right, so we are going to go ahead and get our vitals. You're doing good. We're going to go ahead and get our vitals. And what vitals? What vitals are you going to take?
I'm gonna take blood pressure, pulse, oxygen level,
Okay.
temperature.
Okay.
Well, like with the back of your hand.
Yep. All right. So blood pressure is 128 over 80.
Perfect.
Respiratory rate is 14. Pulse rate is 120. All right. And one thing that we're going to check too that's in our vitals is pupils, right?
Pearl.
So pupils are going to be pearl. Do you remember what pearl means?
Pupils equal and reactive to light.
Okay. And then SpO2 is going to be 97%. Okay. And then you're going to go through, since we're going through everything, remember a trauma and a medical assessment is the same exact. We're going to go through everything. So what type of questions are you going to ask your patient throughout the medical history?
Allergies, medication
No. What?
intake.
Yeah, very good. But what type? Like, as in, are you going to ask yes and no questions? No. What type of questions do we call those so we can get an answer?
I can't remember what it's called, but
Open
open-ended questions.
There you go. You're getting it. All right. So if you were going to ask the patient history of present illness, what is that going to include? The history of present illness. What is the mnemonic that we use? For history of present, there's only a few mnemonics once we get into patient assessment that we use. One of them we were taught since we were EMR and EMT.
Isn't it the OPQRS?
Boom. And do you remember what it stands for?
Oh. It's been so long since I've done this.
No, you're doing good.
Dang, it was on the tip of my head.
Do you remember the type of question that you would ask? Do you remember the question?
It's onset, provocation,
Okay.
quality.
Right. Yep. R.
Radiation.
Yep. S.
Severity.
Mm-hmm. And T?
Is time.
That's right. T is time. All right. For onset, what type of what would be the question you would ask for onset?
What were you doing when this happened?
Awesome. For provokes or palliates, what type of question or what question would you ask?
Is there anything that you do that makes it worse?
Makes it better or worse? Yep.
Better things?
Um, and for quality, what type of question would you ask, or what question would you ask?
It'd be like 1 to 10. What's your
Okay.
pain?
On a scale of 1 to 10, 10 being the worst pain you ever felt in your life, how would you rate your pain? And they'll give it to you. All right. For the next one, radiation, what question would you ask?
Uh, does pain stay in one spot or does it go to another?
Okay. On severity, what would you? Oh, sorry, I screwed this up. I wasn't paying attention. For quality, what question would you ask? Let's go back to that. I was wrong on that. For
Yeah.
quality, sorry.
Quality. Let's see. Is it a sharp or dull pain?
Well, we don't want to
That's
lead them.
yeah.
So what will we say?
I don't even remember.
What we does somebody want to help him out? What will we say for quality? Does anybody remember? Mm, or you could say could you describe to me your pain? Could you describe it to me?
Oh yeah.
How does it feel? Is good. Description. Asking for a description because that kind of tells them that hey, I'm gonna have to talk to you, right? So you can say how does your pain feel, but you're looking for the description, right? All right. So next, radiation. We covered that. Severity at that time. Severity covers 1 to 10, right?
Yep.
All right. So time. What will we ask?
Uh, time. How long has this been happening?
Sure. Since I got cut.
Yep.
All right. So next, we're gonna ask questions that are related to past medical history. All right. Almost said it. What questions? What mnemonic do we use?
Uh,
It's the old school one. It's the one that we've learned from the beginning.
for for sample history.
Boom. There you go. So and what are those? What are
Signs and
those?
symptoms.
Mm-hmm.
Allergies. Past medical medication. Last oral intake and events.
Yep. So for signs and symptoms, signs are things that what?
That you can see.
Just like a sign, and symptoms are
What
things
they
that they,
feel.
yep, what they feel or what's going on with them that they know. Allergies, you're going to ask about allergies. Mostly, what type of allergies are we looking for? We're looking for allergies, yes, but for the most part, we're looking for what type of allergies.
Life-threatening allergies.
Mostly drug allergies.
Drug allergies.
Yep, most of the time we're looking for drug allergies. For medications, we're looking for what type, and when we're asking for medications, we say medication supplements, anything like that, right? Because you don't know what they've been doing. Um, so that's a good one to kind of look at now. And then past illness. So we're looking for past pertinent illness, right? And so we're looking for past pertinent illnesses. Last oral intake. What type of questions are we asking for that?
When's the last time you ate?
What was the last thing you ate or drank? Yep. And then events leading up to.
What were you doing when this happened?
That's right. Probably running his mouth. Right?
Drunk.
Drunk. He got cut on the leg. Old boy pulled a knife out and cut him on the leg. Jugged him in the calf, I guess. All right, so you see this patient as a. He's a stable patient. So he's Stable patient, you got his set of vitals, and now at that point you can get your refusal, right?
Yep.
You can get your refusal, and usually what comes with a refusal?
Signature.
Signatures. Signatures from him, and then signatures from a witness, right? And yours. Well, yeah. Any non-bias, yeah, person out there would be good. Police officer, or somebody else. Just you kind of don't want both the people in the same truck. You and your partner signing up on it. So if there's a firefighter or if there's a police officer or something like that, then you can do that. It makes it better. So once you get and then also a set of vitals usually comes with that as well, because you still got to do a refusal report. So they generally want a set of vitals for that, for the report. So you want to make sure that you put that on. We got here. All right. So he signs a refusal, and y'all head out, right? Go to lunch. Just don't grab a beer on the way out. All right. So that one, once you can see it starts knocking off the rust of how it goes, asking the questions. I want to get a little interactive thing with it so that we can do that. But I got to see if everybody can touch screen or use their mouse to move around. I'll open up a whiteboard with a person on it, and then they can point and click and all that jazz. All right, very good. He is a stable patient, right? Yes. Of course he is. Very good, Mr. Wade. I appreciate it.
No problem.
You can close it out. Good enough. We will press on. I appreciate it. All right, so you saw it. There's really nothing to it. The first few, I want you to have your skill sheet. That way you can read down it. And I want you to write stuff down, because when we start, I want you to do it just like you're on scene, because we're going to start trending. And it may be soon enough that, all of you that are involved as well, or that are not involved as well, there may be a time where the discussion is, I may have a discussion based on the patient scenario that we had in class. So you may hear all of it and get the information, and then I may ask you to write the report on it, and that'll be kind of the discussion grade. Does that make sense? All right. I see everybody is excited today. I hear you. All right, let me see here. I'm stuck on this page. Well, if you're writing stuff down, writing your own notes, then it shouldn't be an issue at all, right? Because you'll be kind of going through in your head what you thought, and if you want to add anything, you can do that. All right, where's my share screen button? All right, so today we will be going over principles of pharmacology. This is everybody's favorite subject, right? Is principles of pharmacology. I know everybody gets excited about principles of pharmacology, or pharmacology, period. All right, can everybody see the screen? Outstanding. If you can't, let me know. Mr. Wade set the bar today, so what is today? Monday? So Wednesday, we'll see. All right, so moving forward, Chapter 12, Principles of Pharmacology. It's not a very big chapter, but there's a lot to cover because pharmacology is pretty important, right? We got to know what we're giving to our patients and what we shouldn't be giving to our patients. All right, so moving on with the National EMS Education Standard competencies. You see there. All right, as you can see there, administering medication is serious business, as you know. Used appropriately, medications may alleviate pain and improve a patient's well being. So, it does good. Used inappropriately, medications may cause harm or could kill your patient. So, we definitely want to make sure that we are not using it inappropriately. So, we want to make sure to study our pharmacology and what have you. Uh, Cards. What do you call them? Study cards, flashcards are very good. To this day, I still have my flashcards in my bag from paramedic school. So and whenever I wasn't doing paramedicing that often, I brushed up. I brought my flashcards in and I would brush up on them. So like if I were to get back on a truck right now, those flashcards would be handy in my bag. And I'd be brushing back up on them just to make sure. Uh, as an AMT, you're going to administer certain medications to patients, right? And you're going to help patients also self administer other medications. Uh, you're also going to make sure that you ask about medication allergies. That's what we were talking about there. And you're going to report patient information to the hospital personnel once you get there. So that they know what type of medications they take or what they've been taking and their allergies. That's very important for us to know. All right, so AMTs who don't understand how medications work, you're going to place yourself in you and your patients in danger. You're going to place yourself in an out of job experience. So, says there a drug profile gives all the specifics about a drug. Uh, it's included on the package insert, and it's also listed in various pharmaceutical publications that you can look up. You should familiarize yourself with the drug profiles of the medications that you may be expected to administer. There is a table, 12-1. It lists the components of a drug profile. All right, so drug terminology. Pharmacology is the study of properties or characteristics and effects of drugs and medication on the body, right? So, drugs, chemical agents used in diagnosis, treatment, and prevention of disease. The term drugs and medications are often used interchangeably, and however, drugs may make some people think of illegal substances, so we try to use the word medications whenever possible. Especially when you're interacting with patients and families, because you're like, what type of drugs you take, and even though sometimes you are looking for that, I take crack, okay, but you're looking for medication, so separate it out, or you look. So what I generally say, if I'm talking about drugs or illegal drugs, I say illicit. Have you been taking any type of illicit drugs or alcohol or anything like that? And then medications, I keep that separate. Do you take any medications? And sometimes they'll tell you pills that they take that aren't necessarily theirs. So moving on. All right, dose. Dose is the amount of the medication that's given. It's dependent on the patient's size, the patient's age, and whether the patient is an adult or a child, and the desired action of the medication. Right. The action is the therapeutic effect or intended effect that a medication's expected to have on the body itself. expected to have. Doesn't mean it'll always have that. I don't know who my wife is on the phone with, but she is being loud. All right. And for some reason, there we go. I'm trying to turn my light on. There we go. All right, so unintended effects. Those are effects that are undesirable but pose little risk to the patient. Unattended effects. They pose little risk. Untoward effects. There are effects that can be harmful to the patient. So untoward is harmful. And then toxicity is the risk that a substance will pose a health hazard to an individual or an organism. Okay? Very easy, right? Anybody can read a slide. All right, your indications are the therapeutic uses for a particular medication. So when you're looking at the indications, that's kind of going along with what is it you're trying to change, or what is it you're trying to help with. So for therapeutic uses. So if you're looking for such and such drug to help with such and such illness or injury, then it's going to tell you. A contraindication, times when you should not give the patient medication, even if it's usually indicated for that condition. So there are in your medications there are contraindications, certain illnesses, injuries, anything like that that may be occurring that you should not give this medication to the person because of the said injury or illness. A medication is contraindicated when it can harm a patient or it has no positive effect on the patient's condition. That's when it's contraindicated. Simple enough. All right, so medication names. So the drugs we use are derived from 4 principal sources. You got animals. Insulin's usually prepared from the pancreata, I think that's how it's pronounced, of animals, mostly pigs. You got vegetable, which are your plant sources, your roots, leaves, flowers, seeds, and then you have minerals like calcium, iron, magnesium, and then you have synthetic compounds. Those are drugs manufactured synthetically. Synthetic forms are vitamins, steroids, narcotics, things like that, right? All right, trade name. That's the brand name. That's the brand name a manufacturer gives to a medication, like Tylenol or Lasix. Proper nouns that begin with a capital letter, that's going to be the trade name. If it begins with a capital letter, it is the trade name. One drug may have one or more trade names depending on how many companies manufacture it. Kind of like acetaminophen there's all sorts of types of acetaminophen, right? And then you got a generic name. So generic name is usually the original chemical name of the medication, like ibuprofen is the generic name, ibuprofen. Usually suggested by the first manufacturer and it's approved by the U.S. and Food and Drug Administration, or the FDA. All right, so some of the medications are called by their generic name more often than their trade name, like nitroglycerin. Okay. All medications licensed for the use in the United States are listed by their generic names in the USP, or the United States Pharmacopoeia. All right, next you got chemical names, which the precise description of the medication's chemical composition and molecular structure is what their chemical name is going to be. Up next, you got their official name. Their official name is the name assigned to the medication by the USP, and then usually the generic name followed by USP. So if you see any questions or anything like that that says, "Hey, is this a generic name or an official name?" You'll see on there ibuprofen USP. That's the official name. If you just see ibuprofen, then that's probably the generic name. All right, examples of various names for one drug, right? So, chemical name 9-chloro or 11 beta 1721, so on and so forth. That long name there. The generic name is going to be what is that? Boclomethazone, dipropionate, or dipropionate. The official name for that is going to be that. Where I know they just put this in here just so I could try and pronounce it. I know that's why they did this. I'm a fireman. Y'all can read. Not a doctor, Jim. All right, so prescription medications are distributed by pharmacists according to a physician's order, which has got a license number to it and everything else. Over-the-counter medications may be purchased directly without a prescription. Many problems attributable to prescription medications may become more common as more drugs become available OTC or over-the-counter. All right, you may also encounter patients who have taken street drugs, so like heroin or cocaine. Street drugs lack purity of over-the-counter or prescription medications. They're still pharmacologically active and will cause an effect. Now, what type of drugs do we call those? We call those schedule drugs, right? Schedule what? Because there's schedules for drugs. And then there's a schedule for your illicit drugs also, because they're still considered medications, or they're still considered a drug per se. All right, so sources of information or sources of drug information. There are numerous references to learn more about a particular drug. So one of them, you have the AMA, or the American Medical Association drug evaluations. You have the physician's desk reference, or the PDR. You have a hospital formulary that you can use. Local publications that delineates which drug are used in a particular facility. You also have drug inserts that's packaged with the medications. It includes information related to the preparation, the dosage, the effects, the side effects, and other information in there. There's a table in your book that shows this very well. There are also numerous other texts and sources included on the internet also. AMTs should be familiar with these resources and field references, particularly regarding medications encountered in the pre-hospital setting. So you could actually go to your service that you're going to go to get your particular formulary. I know for paramedics in the state of Mississippi, EMTs should have it also. The Mississippi Department of Health, per se, you can go to their website and get into their formulary, and it will actually have a list of drug or a list of medication list for AMT or for paramedic. Excuse me. I don't know why I act like I didn't get no sleep last night. Because I did. Alright, so manufacturers or regulations, U.S. regulations of pharmaceuticals. So manufacturers of pharmaceuticals in the U.S. And most other countries are subject to a variety of laws and regulations, as you can see. Um, they're intended to protect the consumers, and then it's also to prohibit manufacturers from making false claims about the benefit of their drug. This started up because back in the day, somebody would bring some sort of tonic out there and be like, "Hey, this tonic here, step right up. This will clear your sinuses. It will also make your hair grow. It will also do this, do that, and just to get people to buy them." Now you can't do that. You can't make false claims about stuff like that. It requires the manufacturer to publish the information about their side effects and known potential harmful effects of their products as well. The outline standards for drug manufacturers to ensure that drugs produced by different manufacturers are uniform in strength and purity. It outlines those standards. So, drug standards are published in the USP and the National Formulary. Several federal laws have been enacted to protect patients from unsafe substances and unscrupulous manufacturers and distributors as well. I've got to get some WD-40 for this seat. This thing is squeaking. All right, so drug-related legislation. You got the Pure Food and Drug Act of 1906. That was the first federal drug-related legislation in the U.S. And it was aimed at protecting the public from foods, medications, and alcoholic beverages that may be mislabeled, poisonous, or otherwise harmful. Right? The Food, Drug, and Cosmetic Act is 1938 is when it came out. It was amended in 1952 and 1962. After that, it added several new provisions to it. So it requires drug makers to label their products indicating warnings about possible side effects. It's authorized the creation of the FDA. That's what made the FDA, or where the FDA came from. And then it's mandated that dangerous drugs could be dispensed only with a prescription. So that's what kind of where prescriptions came up from. The Harrison Narcotic Act of 1914. It's regulated the import, manufacture, and prescription and sale of several non-narcotic drugs and cocaine, opium, and their derivatives. It's required precise record keeping about the dispensing of controlled drugs. It's also required registration of distributors such as pharmacists, right? Illegal possession or distribution of controlled drugs could result in fines and imprisonment because of this Harrison Narcotic Act of 1914. The Narcotic Control Act of 1956, it increased the penalties for violation of the Harrison Narcotic Act. It made possession of heroin illegal, and then outlawed the acquisition and transportation of marijuana. All right. Let's start off. Let's take a 10-minute break before we start heading off into this anymore. I guess I shouldn't have done that. All right, so 10-minute break. Let's have at it. I'll see y'all in 10 minutes. All right. They're fixing to have to turn the air conditioner on in this house. Sorry, I had to send a message to my lovely family to turn the air conditioner down. I got the coolest little thing. So, we're big Alexa fans here at the house. I don't care if they're watching me or not. It's no big deal. If you think that somebody's not watching you, then you're the one that's been fooled. You are being watched. So anyway, we got all the Alexa devices in the house. We got a few of the Echoes with the screens, and then all the TVs are Alexa devices. The lights and all that good stuff, Philips Hue devices. So on on here, I can do the announce function. It's pretty awesome. I can actually take and speak into the mic, or I can I can text to it, and what it does, if anybody's watching TV in another room, what have you, it'll turn the TV off. It'll go to the announcement, and it'll say my announcement. They just came about with some new noises that you can get with it, like a trumpet and air horn. So you can add that to it. So like you can start off with the air horn. What it's also got is flatulence that's on it. So generally, what I do is I start off with a few trumpets. It'll go bah, 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 and then I'll make my announcement, and then I'll end it with the flatulence. So everybody knows it's me in the house, and then usually what it does, it successfully kicks my son off of any video games that he's playing, and it kicks my wife off a 90 Day Fiance if she's watching that, which is okay if it kicks that off. All right. So, drug related legislation continued. The Controlled Substance Act, one day. It could be 2 day. It's all right. We all got to go somehow. So, the Controlled Substance Act of 1970, it's a comprehensive legislation dealing with narcotic and non-narcotic drugs that have potential use for abuse. The specific, or this specifies the requirements for registration, procurement, storage, distribution, record keeping for the drugs, penalties for failure to comply with these requirements are also in there. Drugs covered are classified into 5 categories or schedules, like we were talking about earlier, right? We hit on it a little bit. According to their abuse potential. So Schedule 1 drugs have the highest abuse potential and a propensity for severe drug dependency. Those drugs, Schedule 1 drugs, are completely outlawed. On rare occasions, under control of the FDA and Drug Enforcement Agency, or DEA, these drugs may be used for research, analysis, and instruction only. Okay? Schedule 5 drugs include drugs with the lowest abuse potential. If you look on table 12-3 in your book, it lists these schedules, including descriptions and examples for the schedules. If the state law is more stringent than the federal law, the state law takes precedence. So the state can only make it stricter, it can't make it looser. Makes sense, right? Excuse me, I had to sneeze. Gesundheit. As an AMT, you should be aware of the laws in your state and always follow your local protocols as well. So, manufacturing regulations. Federal legislation also focuses on guaranteeing standardization of doses. Standardization assures patients when they take the medication with a stated amount of the active ingredient that they will receive that amount of the drug. Okay. For a drug to carry a USP label, the amount of active ingredients must be within 95 to 105% of the stated label. Good to go. So there are a few government agencies that regulate drugs, those being the FDA, Food and Drug Administration. It enforces the Food, Drug, and Cosmetic Act. It also determines safety and efficacy of drugs before they are allowed to enter the U.S. market. Also, the DEA, or the Drug Enforcement Administration, formerly the Bureau of Narcotics and Dangerous Drugs. It's created by the Federal Controlled Substance Act of 1970, and it is a division of the Department of Justice as well. It's responsible also for executing provisions of the Controlled Substance Act. This includes the registration of physicians who are permitted to dispense controlled substances. So if you see any bust or a DEA bust or anything like that at a doctor's office, probably know why. Up next is going to be the Public Health Service. It regulates the biologic products. Biologic products are medications made from living organisms. So this is going to include things like antitoxins and vaccines. The Federal Trade Commission, or the FTC, it monitors drugs. It monitors drugs advertising to ensure it is not misleading or inappropriate. It makes recommendations also to the FDA regarding direct to consumer or DTC advertisements as well. It also found that direct to consumer advertisements generally benefit consumers, but stated ads should contain a major statement of drug risk along with adequate provisions for more complete risk information. It's when you get on there and it talks about something and it says may cause diarrhea, heart palpitations, death, so on and so forth. Good Lord. So the drug approval process, new drugs are constantly being developed. The commercialization process takes years. The average time for a drug to be developed, tested, and approved is about 9 years. 9, count them up. In some cases, manufacturers found out that the drug does not work as envisioned or is too dangerous for human consumption. All new drugs must go through animal studies and clinical trials in humans before approval or distribution. Animal studies are designed to learn more about the properties of the drug and to identify tissues and organs that are sensitive to the actions of the drug. Testing in at least 2 animal species is required by law. And then, after successful completion of animal studies, an investigational new drug may enter clinical trials in humans after that. So that drug approval process continued. Clinical trials, phase 1 of clinical trials. The new drug is tested in healthy volunteers to compare human data with those in the animals that were previously tested. And it determines doses, the safe doses of the drug, and then assesses the medication safely as well. Phase 2 is performed in homogeneous populations of patients, so 50 to 300 patients. In a double-blind study, one group receives the drug and the other group receives a placebo or a sugar pill or whatever you want to call it. It's designed to evaluate the efficacy and the safety of the drug. It also establishes which form is the most effective dose as well. Phase 3, nope, that's not. Phase 3, the drug is made available to a larger group of patients, several thousand patients at that point. These studies usually last for several years, and it evaluates the efficacy of the drug, monitors the nature of the incidence of side effects also. Then you have phase 4. So company developing the drug can apply to the FDA for approval to the market with the drug. And then it also compares the new drug with others on the market and examines the drug's long-term efficacy and the cost effectiveness of the drug. Phase 4. So, drug storage and security. All right, drug storage and security for controlled substances, more of. All drug containers or boxes should be carefully guarded against possible theft. All right, depending on how your ambulance does it, then they'll have their own rules and regulations that are abided by that. So it requires the boxes, they have to be locked and they have to be secured within the ambulance. Certain precepts guide the manner in which the drugs are secured, stored, distributed, accounted for. And then your local protocols are going to dictate the manner in which the drugs are maintained for that. If controlled substances such as narcotics are administered, the records must be kept separate from other paperwork. So the DEA strictly regulates those substances, right? If drugs are lost or stolen, the supervisor and law enforcement personnel must be notified immediately. So we talk about wasting and things like that, or having a document for that, or empty vials, anything like that. So all medications should be stored in an environment with a constant temperature if all possible. All right, so that's something that we look at too, not just medications, but also your fluids. So pay very much so attention to your fluids, because that's going to be the most thing that you guys have, guys and girls. So your fluids need to be, during the winter, you need to make sure those fluids stay warm, not too hot. Don't be putting them on the heater and then getting them too hot and it feels like fire when they're going through a patient's veins. But you don't want it to be cold, because you may induce hyperthermia or you may induce hypothermia at that point. All right. Some of these drugs also, and some fluids, it does the potency of the medication. It's affected by the temperature, light, moisture, shelf life, and exposure to air. If control medications are not used before their expiration dates, they must be destroyed. So the destruction has to be witnessed by 2 employees and documented on all the proper forms, waste forms or what have you. So some special considerations in drug therapy. So pregnant patients, before you administer medications to a female of childbearing age, ask the patient whether she could be, I almost said she or he, whether she could possibly be pregnant. In an emergency, the woman's health takes priority, of course. And then before administering any drugs to a pregnant woman, expected benefits should be considered against the possible risk to the fetus. Okay. Prescription and over-the-counter drugs have the potential to harm the fetus or the newborn, right? So, like a teratogenic drug. It's a drug that poses a risk to normal development or health of the unborn fetus. And changes in a pregnant woman's body affect the way that drugs are processed and may increase a chance of harm to the fetus as well. So, metabolism of the drug in their liver is decreased during pregnancy. So, something to think about. Increased rate of excretion owing to increased cardiac output during pregnancy as well. The FDA has established a scale with categories A, B, C, D, and X to indicate drugs that have documented problems in animals and or in humans during pregnancy. So the category A drugs pose the least risk, while category X drugs pose the greatest risk. The five category system it's being replaced by a more detailed system currently. Medications approved after June 2015 have only the narrative summary for it. There's a table in your book that outlines the pregnancy categories for both classification systems. There are also still many drugs with unknown effects during pregnancy as well. You must be able to quickly evaluate the risk versus benefits of drug administration. If the drug is the only option for saving a woman's life, then that consideration should be paramount, right? When in doubt, also, who do we contact? Anybody know who we contact? You got it, dude. All right. Following on with special considerations in drug therapy, pediatric patients. Medications have much different effects in adults than in children. Young infants have a sharply reduced metabolic capacity, so that's got to be considered. Incomplete development of the gastrointestinal tract, it slows the absorption of oral medications and it delays elimination. So it hangs out longer, right? The same medications may be more potent in an infant than in an adult, not just because of size, but because of the way their body system works. All right. Children can metabolize some medications much more quickly than adults and may require relatively higher doses or more frequent administration. Products of metabolism in children can vary from those seen in adults, which sometimes result in unexpected responses as well. Isn't there a chart ruler thing that you can get for pediatric drug administration? I don't know. Mr. Walker. What would we call that ruler thingy? Okay. Has anybody here ever used one? Braslo tape? Oh, we're doing that now, are we? You do. I figured you did know that. Your medic doesn't use a Brazlo tape, or he doesn't work on pediatric patients. I would ask who your normal medic is, but we won't incriminate you. It's probably Jody. Yes, it's called a Brazlo. It's called a Brazlo tape. And it's very useful, and definitely make sure your truck's got it, because at the time that there will be a time, if you're not paying attention, that you'll go to a pediatric call and somebody be like, "Can you break out your Brazlo tape?" And if you say, "I don't know if I have one," or if you say, "I don't have one," that is your sphincter your sphincter muscle is gonna be like this. It's gonna be like that. That is something that you definitely need to make sure that you have. All right, so geriatric patients. Changes in pharmacokinetics are in geriatric patients are comparable to those in young children. The hepatic functions and the GI activity slow also in older patients, which delay absorption and elimination. Yeah, Ty. Geriatric patients are often taking several medications at a time, so that's something very important for you to look into. When you have a patient that's got a bag full, I always make sure that I look at every drug that they have, write them down, and that's why it's good to know those main drugs, or how they're used, or what their indications are, or what have you, their classifications. Mostly their classifications. If you know a drug's name and then you can put it in a classification, that can help you to kind of figure out what that drug does. And then what you'll have is patients that have a couple doctors and several medications that have been put in a bag that they're all taking all at once or whatever. And then you can start to look and be like, well, this drug is, it's a contraindication to have this drug and this drug together, or they have different types of effects. And I think we're going to get into those effects, like the synergistic effects and things like that. We'll talk about those. So, as an AMT, you are legally, morally, and ethically responsible for each drug that you administer. You must have a good foundation of knowledge of OTC and prescription medications that may interact with drugs that you give. Okay? That you give. You must have enough knowledge to obtain a medical history for patients who are unable to communicate as well. Drug administration must be safe and therapeutically effective, right? So you should always keep a field guide or other medication reference handy to look up unfamiliar. Do it to it. Look them up. If you need to. And you got to follow the standardized national guidelines also. And that is in your book and a table. So, up next, what are drug classifications, ask? Here's where we talk about it. So, classifications of drugs are based on the effect drugs will have on a particular part of the body or on a specific condition. That's what I was talking about. If you know the classification, it'll help you tremendously. So many drugs fall into one or more, into more than just one. Sorry, to more into more than just one. Drugs or medications can be classified into three categories. Three. So you got the body system. It's categorizing of the system affected by the drug. Uh, Understanding which system are affected by which drugs will help you make the appropriate decisions for patient care as well. It's got the class of the agent. Uh, that's going to tell how a medication affects the system. And then mechanism of action. And that's going to be the particular action by which the drug created is its desired effect on an organism. What its desired effect is on an organism. Yeah. All right, so you also have nervous system classification. The nervous system, it's the body's principal control system, right? So this in review, the CNS is made up of the brain, spinal cord, peripheral nervous system, right? It includes all the nervous tissues outside the CNS as well. Peripheral nervous system contains the autonomic nervous system, or the ANS, which controls the automatic or involuntary functions. The ANS, it's also divided into the sympathetic nervous system and the parasympathetic nervous system. Parasympathetic nervous system is responsible for the body's response to shock or stress. It's known as the flight or fight division. And then the response associated with the release of adrenaline from the adrenal glands, release of hormones epinephrine, like adrenaline, and norepinephrine or noradrenaline. That's what it do. The sympathetic responses include shunting of blood from the extremities to the vital core organs, and then dilation of the pupils and reduction of digestive system activity. Parasympathetic nervous system relaxes the body. It controls the automatic functions during non-stressful times. It's referred to as the rest and relax division. Okay. Stimulation results in effects opposite of the sympathetic nervous system. And then examples would be like the heart, respiratory rate decrease, constricting of the pupils, and increasing digestive system activity. The parasympathetic or the sympathetic and parasympathetic divisions work in constant opposition to maintain basic harmony in the body. Each division takes more precedence in proper circumstances. All right, these are the big ones here. Also, so carrying on with the nervous system classifications, hormones released by sympathetic nervous system or system stimulation are carried through the body where they cause an intended effect by acting on hormone receptors. Okay? That stimulate the tissues that are not innervated by sympathetic nerves. It also prolongs the effects of the direct sympathetic stimulation as well. The adrenergic receptors are located throughout the body, and once stimulated by the appropriate hormone, they cause a response in the target organ. These are generally divided up into four types. You got alpha 1, which you see there is denoted by the A1, the alpha 1. You got alpha 2, which is denoted by the A2, beta 1, and beta 2. Okay? Alpha 1, alpha 2, beta 1, beta 2. Know those. Know those. So drugs affecting the parasympathetic nervous system, sympathomimetics are drugs that produce the same effect on a body system as the hormones of the sympathetic nervous system, right? Sympatholytics are medications that inhibit the sympathetic nervous system. Sympatholytics are medications that inhibit the sympathetic nervous system. Okay? They're also known as anti-adrenergics. Anti-adrenergics antagonize or fight against the effects of the sympathetic nervous system. Clear as mud. Then you have antagonists, which drugs that counteract the action of something else. And then you have the agonist, which are drugs that bind to the receptor and cause a response. So some medications stimulate alpha and beta receptors, whereas others are selective to specific receptors. Beta blockers are used to control blood pressure in some patients and heart rhythm disturbances in others. They work by filling a portion of the beta receptor sites, and beta stimulators would normally bind to that. All right. Beta 2 selective drugs cause bronchodilation with little effect to the heart, which only has beta 1 receptor sites. So the heart only has beta 1 receptor sites. So drugs affecting the parasympathetic nervous system, parasympathomimetics, agonists to the parasympathetic nervous system. They're also called cholinergic medications because they stimulate the cholinergic receptors to which acetylcholine, or ACH, normally binds. Acetylcholine. Cholinergic medications may act directly or indirectly on cholinergic receptors. An anticholinergic drug, acts to prevent activation of the receptors by binding. When a drug interacts with acetylcholinesterase, or ACHE, deactivation of ACH does not occur. If excessive cholinergics are present, the patient may exhibit the sludgem symptoms. Does anybody remember what that is? Sludgem symptoms? All right, so there are certain times. Does anybody remember sludge or sludgem? What type of exposures we're looking for when you have to use sludge or sludgem? You remember that from EMT? Agent Orange. Sure, yeah. Yep. So, sludgem, since you're on it, so S being salivation or sweating, L being lacrimation, U being urination, D being defecation, drooling, or diarrhea, G being gastrointestinal upset or cramps and cramps, E being emesis or bleh, right? M being muscle twitching meiosis. So, in patients exposed to certain fertilizers, insecticides, VX, which is a nerve agent, and sarin gas exhibit sledgem symptoms. Okay. Funny you mentioned Agent Orange. So on the base I live on right now was one of the biggest transporters of Agent Orange during Vietnam, and it was literally about a mile or if that from my house. There's a huge concrete cap over where the building was knocked down. There's a huge concrete cap that's over that base area or over the foundation. It's huge. It's super thick concrete cap. It's pretty interesting to read about. That's what's wrong with everybody in Gulfport. All right. Parasympatholytics. So, antagonists to the parasympathetic nervous system. It's an antagonist to the parasympathetic nervous system. Atropine is one of the most commonly used parasympatholytic. It's also called an anticholinergic medications because they block two types of cholinergic receptors: the muscarinic and the nicotinic receptors. The muscarinic cholinergic antagonists block ACH exclusively at the muscarinic receptors. Example of that would be atropine. So, analgesics and antagonists. Analgesics are medications that relieve pain and induce analgesia, which is the absence of sensation of the pain. And then opioid agonist, most common class of medication used for analgesics in the pre-hospital setting. It's similar to or derived from the opium plant, and then it binds opiate receptors, which prevent neurons from sending pain signals. CNS depressants are going to be like that. Fentanyl or sublimase, fentanyl or what we call sublimase is a popular opioid agonist because it's rapid acting and it's very potent and has a relatively short duration of action as well. Non-opioid agonists, many are available as OTC drugs. Many have antipyretic properties as well, meaning that they reduce your patient's fever or your fever if you're taking them. All of them alter the production of proglastinase, or prostaglandins, prostaglandins, and COX, because I'm not even going to try that word. So COX is short for it, to produce their effects. Three forms are particularly popular, like salicylates, which an example of that is aspirin. Aspirin targets the COX-1 enzymes to reduce platelet aggregation. Running a little late today, we see. And then it's also it provides great benefit in patients who are suspected of having a myocardial infarction as well. All right. Then you have non-steroidal anti-inflammatory drugs, or NSAIDs. So NSAIDs, an example of that would be like ibuprofen. It's designed to reduce pain, inflammation, and fever. So it works by inhibiting the COX chemicals, and which produce the chemical prostaglandin, and which promotes pain, inflammation, and fever. Prostaglandin promotes pain, inflammation, and fever. NSAIDs get rid of that crap, right? Then you also have para-aminoferryl derivatives. An example of that would be like acetaminophen or Tylenol. You also have opioid antagonists, which reverse the effects of opioid drugs. What is a popular opioid antagonist? It's right there on the screen. Narcan is or naloxone is a popular opioid antagonist. And it's the most common in the pre-hospital setting. So opioid antagonist have agnostic or have an agonistic and antagonistic properties, often preferred because they can decrease pain but not diminish function of respiratory system or lead to dependence or addiction. So anti-anxiety, sedative, and hypnotic drugs, possibly, yeah. Suboxone, that's a good one. I hadn't heard that one in a little while. So anti-anxiety, sedative, and hypnotic drugs. So drugs are used to help a patient sleep through a medical procedure by producing sedation and hypnosis. Okay? Drugs that create sedation and hypnosis are going to include things like benzodiazepines. Sedatives most commonly, this is a sedative most commonly used to prepare a patient for invasive procedures. The exact mechanism of action is not fully understood as of yet. That's why we call it practicing medicine, right? It's believed to affect the neurotransmitter or the neurotransmitter gamma aminobutyric acid, or GABA, in the brain. Up next, we got barbiturates. So barbiturates are believed to work very similarly to benzodiazepines by increasing the affinity between receptor sites and the neurotransmitter GABA, or GABA. Romazicon, that's a good one there. That's a good one. Romazicon. Non-barbiturate hypnotics they have identical properties to benzodiazepines and barbiturates in how they affect GABA receptors or GABA receptors. However, they tend to have comparatively few side effects, particularly in terms of cardiovascular compromise. All right, anticonvulsants. A seizure is a state of neurologic hyperactivity, right? So active seizures generally require treatment in the pre-hospital setting due to associated complications with that. Anticonvulsant medications, the exact mechanism behind them are not completely clear as of yet. Again, practicing medicine. Uh, it's believed to work by inhibiting the influx of sodium into the cells. It decreases the cell's ability to depolarize and propagate the seizures. And then several other ideas or several other types of drugs, are used as anticonvulsants, including benzodiazepines, barbiturates, uh, hydatines, and valproic acids also. All right, let's do this. Let's take another 10-minute break. And we'll be back before we get into stimulants. Alrighty. Stimulants. Everybody back? Everybody happy? Let's rock and roll. So, stimulants. Stimulants are a common group of CNS agent. They exert the action by excitation of the CNS or the central nervous system. Stimulation of CNS can be accomplished by increasing excitatory neurotransmitters and then decreasing inhibitory neurotransmitters. Examples of this are going to include caffeine or cocaine. Prescription and illicit amphetamines are also examples of this as well. This is going to increase the release of dopamine and norepinephrine to increase the wakefulness and awareness and reduce drowsiness and fatigue as well. It's going to increase tachycardia and hypertension. So if you got that, that's probably not a good thing for you, right? And it can cause seizures and psychosis, which is never good, or errant cleaning of rooms and things like that. High doses can cause increased nervousness, irritability, tremors, headache, things like that. Some people experience withdrawal symptoms when they stop taking these stimulants. Up next, we have depressants. So, central nervous system agents that slow the brain's activity may be prescribed to treat anxiety, muscle tension, pain, insomnia, stress, panic attacks, and seizures. Some central nervous system depressants are used as anesthetics. Some examples of this include lorazepam or Ativan, diazepam or Valium, alprazolam, aprazolam is Xanax, and zolpidem tartrate is Ambien. Okay, did you notice something about the stronger ones that you see there? What is the end word or the end two letters of most of them? Pam or lamb or that's right. Pam, 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 Pam. So there are some very good Quizlet flashcards that are on drugs that break all these down like a fraction. It's pretty amazing. Up next, we have psychotherapeutic drugs. They work by blocking dopamine receptors in the brain. They're used to treat illnesses such as schizophrenia and depression, associated with a host of side effects. So, pyramidal symptoms are going to include involuntary movements, tremors, rigidity, muscle contractions, restlessness. Yep, that's right. Restlessness, changes in breathing and heart rate as well. It can also cause orthostatic hypotension, sedation, and can also cause sexual dysfunction. Depression is often treated with selective serotonin as a reuptake inhibitor or SSRI, and then monoamine oxidase inhibitors or MAOIs. SSRI and MAOIs block the metabolism of monoamines in the brain. You also have tricyclic antidepressants or TCAs. They're still occasionally used, but their popularity is waning away. Right? So drugs affecting the cardiovascular system are going to be things like the walls of the heart are composed of many interconnected cells specialized to serve particular functions, right? So medications targeting the cardiovascular system are classified according to their effects on specialized cells. Effects on the heart are categorized as follows. You got chronotropic effect, which affects the heart rate. You have the inotropic effect, which changes the force of contraction, right? The force of it. You got dromotropic effect, which alter the velocity of the conduction of electricity through the heart. Dromotropic. All three of those effects can be positive or negative, of course. And you also have cardiac glycosides. So the class of medication derived from plants, they block certain ionic pumps to the heart cell's membranes, which indirectly increases calcium concentrations. It's associated with numerous side effects. Your cardiac glycosides are. Excuse me. Antiarrhythmic medications is long used in the pre-hospital setting to treat and prevent cardiac rhythm disorders. It can have a direct or an indirect effect on cardiac tissue. It's classified into groups according to their fundamental mode of action on the heart. You have sodium channel blockers, which as far as effects on the heart, it's a slow conduction through the heart, negative dromotropic effect. You have beta blockers, which reduce adrenergic stimulation of beta receptors. You have potassium channel blockers, which increases a heart's contractibility, or positive inotropy. Positive inotropy, right? You also have calcium channel blockers, which decrease the force of contraction and automaticity, and then decrease conduction velocity, which is a negative dromotropic effect. Conduction velocity. Conduction, like electrical. Like a dromotropic. Or dromotropic. Antihypertensive medications. Antihypertensive treat hypertension, and then its treatment goals are to keep blood pressure within normal limits, and then maintain or improve blood flow, and then also to reduce the stress placed on the heart. You have diuretic medications, which cause the kidneys to remove excess amounts of salt and water in the body. It reduces the level of stress placed on the cardiovascular system by lowering the total fluid volume, and then lowering the preload on the heart and decrease the stroke volume. So diuretics lower the preload on the heart and decrease the stroke volume. You also have vasodilator medications. They act on the smooth muscles of the arterioles and veins. All right. So this explains why nitroglycerin is so beneficial in treating myocardial ischemia, because it does what? Opens up it's a vasodilator, right? Which causes, if it's a wider hose, more blood can get through it. Or if there's a clot, in it and it's a wider hose, then maybe it can get around the clot. So vasodilators do a few things. I'm sorry, messed something up. So, along with those, why it's so good at treating myocardial ischemia. However, dilation of these vessels prompts a response from the sympathetic nervous system, right? It's going to prompt that response. When vasodilators are used to lower blood pressure, the patient must also take medications that inhibit the sympathetic nervous system as well. Okay? So with that, sympathetic blocking agents include beta blockers and adrenergic inhibitors. So beta blockers compete with epinephrine to bind with available receptor sites, and this diminishes the effects of beta stimulation. You also have angiotensin converting enzyme, or ACE inhibitors. So these ACE inhibitors that targets the renin-angiotensin and aldosterone system. It suppresses the conversion of angiotensin to 1 to angiotensin 2. Angiotensin 2 is it's a potent vasoconstrictor that promotes smooth muscle contraction in the arterioles throughout the body. Constriction of this raises the blood pressure by increasing peripheral resistance. Calcium channel blockers also have anti-dysrhythmic and anti-hypertensive properties as well. That one slide there is like a few days worth of paramedic school. Anticoagulants, fibrinolytics, and blood components. So platelets repair damage to the blood vessels, right? Defects in blood vessels can cause blood flow to slow down as well. If blood flow slows significantly, a blood clot or a thrombus forms. Abnormal thrombi may cause a life-threatening crisis such as a stroke. A variety of medications are used to prevent or minimize the detrimental effects of that thrombi. Also, things like anti-platelet agents. It interferes with the aggregation or collection or platelets. It does not break down aggregated platelets, and it'll prevent further buildup of these blood cells. Salicylic acid has significant antiplatelet properties. It's important in the pre-hospital setting, and it minimizes damage to the myocardium in acute coronary syndrome, or ACS. Anticoagulant drugs work against coagulation to prevent the formation of thrombi. In some patients, it can be prescribed, these on a long-term basis as a preventative measure. You need to be aware of anticoagulant use. You need to be aware of that, particularly when patients have sustained a traumatic injury and can prevent life-saving coagulation needed to prevent blood loss. Up next, you have fibrinolytic agents, which may be administered to dissolve the thrombus and prevent it from breaking off and entering the bloodstream. It promotes digestion of fibrin, the protein involved in forming blood clots. And then use in the pre-hospital setting remains pretty controversial for that. In some circumstances, other forms of reperfusion therapy may be indicated. So drugs that affect the respiratory system. Oxygen is the most commonly used medication in the pre-hospital setting. It has appropriate and inappropriate uses and some side effects to it as well. Use of OTC decongestant medications is common, especially during cold influenza seasons. Each decongestant varies slightly in terms of mechanism of action. All such medications seek to reduce tissue edema, facilitate drainage, and maintain the patency of the sinuses. Um, Patients may like antihistamines during allergy season. Try to find out which medications your patients are taking if they're taking those. Know the effects of these drugs and what they may have on other medications, and then also know the signs and symptoms they can produce as well. Uh, People have been known to overdose on pseudoephedrine, which is a decongestant. They've been known to overdose on dextromorphoorphan, which is an antitussive, and diphenhydramine, which is an antihistamine. Overdose on them. So, severe respiratory emergencies often arise from severe narrowing of any portion of the respiratory tract, right? So, respiratory tract is lined by smooth muscle fibers that influence the diameter of the airway. Control of the smooth muscles is maintained by the autonomic nervous system, or ANS. Many respiratory emergency treatments attempt to expand the respiratory tract by using sympathomimetic medications. Complications arise when patients with respiratory emergencies eventually experience decreased amounts of oxygen to vital organs. Increased heart rate and greater force of contraction lead to a higher demand for oxygen, which is already in short supply in a respiratory emergency, right? Stimulation of the beta 2 receptors is most beneficial to patients with respiratory emergencies. These drugs produce smaller increases in heart rate and force of contraction, and it dramatically decreases the body's rate of oxygen consumption. Xanthines are second-line treatment in a respiratory emergency. It relieves the airway constriction by relaxing the smooth muscles of the bronchioles or stimulating cardiac muscles to work harder, increasing the blood flow. So it'll also stimulate the CNS, or the central nervous system. Caffeine is a well-known xanthan and CNS stimulant. Caffeine is. Other respiratory medications suppress the inflammatory response that typically causes acute distress for patients with restrictive airway disease. Okay. In the acute care setting, corticosteroids can be administered for the same purpose. So, drugs affecting the pancreas. A variety of hypoglycemic medications are available. Others may not act on the pancreas directly, but may alter the way insulin is used by the body. In the absence of pancreatic function, patients may take insulin injections. Sulfonylureas, sulfonylureas. Somebody else may be able to pronounce that better than I can. It increases insulin secretion from the pancreatic beta cells. It's effective only in patients that have residual beta cell function. Insulin sensitivity is increased by oral hypoglycemic agents also. So drugs affecting the immunologic system. Immunosuppressant medications are often prescribed to patients who undergo an organ transplant or have an autoimmune disease, right? Uh, Immunosuppressants are intended to inhibit the body's ability to attack the foreign organ, or as for organ transplants. It's also used to inhibit the body's attack on itself, such as in autoimmune disease. Generally, it's derived from fungi or bacteria, and it tends to have a complicated mechanism of action as well. Essentially, they inhibit lymphocytes and T cells from carrying out their immune functions, simply put. All right, vitamins and minerals. They're necessary substances that allow for normal metabolism, growth and development, and cellular function. Patients may be taking vitamin mineral supplements to replace deficiencies or as a preventative measure as well. Thiamine is important in the pre-hospital setting, and it aids in converting carbohydrates into energy. People with alcoholism, among others, tend to be deficient in this vitamin. All right, here's some that you need to know as well. So you need to know thiamine. That's a good one for you. Also, why we use thiamine in alcohol patients or alcoholic patients. And then up next, fluids and electrolytes. So this is a good one too, because you will be using these very commonly. So crystalloid solutions, typically used in the pre-hospital setting. It can be isotonic, which provides a stable medium for the administration of medication and provides effective fluid and electrolyte replacements. You also have hypertonic, which helps provide nutrition. And then you have hypotonic, which is beneficial in dehydration situations, not hypovolemic cases, but dehydration. You may also administer colloid solutions to your patients as well. All right, up next, drug forms. So the form that a medication comes in usually dictates its route of administration. So the manufacturers choose the form to ensure proper route of the medication, timing of its release into the bloodstream, and effects on the target organs or body systems. So solid drugs, most medications that are given by mouth or PO, right, to adult patients are in tablet or capsule form. Capsules are gelatin shells filled with powdered or liquid medication. If the capsule contains liquid, the shell is sealed and soft. If the capsule contains powder, the shell can usually be pulled apart. All right, so tablets often contain other materials that are mixed with the medication and compressed under high pressure. Some are designed to dissolve very quickly in small amounts of liquid. They can be taken sublingually, which is under the tongue, right, and absorb rapidly. Sublingual nitroglycerin is an example of this. Especially useful in emergency situations. Very, very useful. It may be ground into powder to be absorbed more quickly, and generally medications that must be swallowed are less useful in an emergency. So, the digestive tract, it provides for a slower route of delivery. That's why. You also have pills, which are solid drugs that are shaped into a ball or oval to be swallowed, often coated to disguise an unpleasant taste. You have suppositories, which are administered by inserting into the rectum, right? And that is more rapidly absorbed than medications that must travel through the upper portion of the digestive tract. Uh, Guess what? You're not going to administer those as AMTs. I know you're all just let down by that. All right, up next, liquid drugs. So you have solutions. This is a liquid mixture of one or more substances that cannot be separated by filtering or allowing the mixture to stand. Uh, can be given by any route. When given by mouth, it can be absorbed by the stomach fairly quickly because the medication's already dissolved, right? Solutions that irritate the stomach can be it can be applied topically to the skin or sprayed sublingually or inhaled. Many solutions can be given through IV, though. Solutions can also be delivered via injection, like intramuscular or IM or subcutaneous or SC. You may need to assist a patient with SL or sublingual delivery of nitroglycerin or IM delivery of epinephrine as for an allergic reaction. Up next, you have suspension, which most substances do not dissolve well in liquids. Some can be ground into fine particles and evenly distributed throughout a liquid by shaking or stirring, right? Examples of this will be like activated charcoal. It's used in patients who have overdosed and ingested certain poisons. Uh, you may encounter several types of liquid drugs that include alcohol in their preparation, like tinctures. So the name of the material contained in the tincture, other than alcohol, is added to the name of the tincture. Spirits are alcohol solutions that are volatile. Okay, elixirs. It's one of the most common types of medicinal preparations taken orally as a liquid. It's made up of a sweetened aromatic and hydroalcoholic liquid. You also have syrups or syrups, mixtures with a high sugar content, designed to disguise the taste of the medication mostly, and most commonly used for children's medications. And then lastly, you have emulsions, which is a mixture of the two liquids that are not mutually soluble. Generally, a mixture of water and oil that must be thoroughly shaken to mix up. Up next, we have metered dose inhalers or MDI. If liquids or solids are broken into small enough droplets or particles, they can be inhaled. So meter dose inhalers or MDI, it's a miniature spray canister used to direct such substances through the mouth and into the lungs. It delivers the same amount of medication each time it's used. It must be shaken vigorously before the medication is administered because the inhaled medication is usually a suspension. Okay. It's commonly used by patients with respiratory illness such as asthma or emphysema. Up next are topical medications, which is it's applied to the surface of the skin. Its affect only the area of application. Locations contain the largest amount of water of all. Lotions contain the largest amount of water of all topical medications, absorb the quickest of the topical medications, and some examples of this, or one example of this, is like calamine lotion. And you have creams, which are absorbed more slowly than lotions, but faster than ointments. Examples of this are going to be like hydrocortisone cream. It's used to diminish skin itching. And then you have ointments, which contains the smallest amount of water, slower rate of absorption of medication. An example of this would be like Neosporin. And you have these transcutaneous medications, also known as transdermal, designed to be absorbed through the skin transcutaneously and can affect other areas of the body. Common examples include nitroglycerin for chest pain and fentanyl for pain management. In contrast to most topical medications or medicines, transcutaneous medications are usually intended for systemic effects. So, you get a patient, and I say this because it happens. I'll always check a patient if I'm just dumbfounded as to why a patient seems like they're under the influence, but I can't find any other indication they're under influence. Or let's say that they have respiratory distress, or they're in some sort of distress, some type respiratory effect. Then the effect, what you have to look at is those transcutaneous patients or transcutaneous medications. Yes, pain patches. Check your patients for pain patches. That's going to be a big one. If you're sitting there and this patient has a low oxygen saturation, and just continual, check them for pain patches. I've also seen patients that chew on pain patches, which is insane because it will knock you down. Yep, check for pain patches. Because you can give Narcan whatever you want, and it's still going to create issues, right? Because those are still there. All right, up next is gels, which is semi-liquid substance. It's administered orally through capsules or plastic tubes. Usually have the consistency of paste or creams, but are transparent. An AMT may give one of these gels, or give a type of medication in gel form for certain illness or injury. Do you know what medication I'm talking about in gel form that you give? EMTs can assist with it as well. Yep. Glucose. Oral glucose for low blood sugar. Why I keep getting these messages. No telling. No big deal. All right, so some others you have are gases. It's neither solid or liquid, and most often delivered in the operating room. Oxygen is the most commonly used medication in gas form in the pre-hospital setting. In concentrated form, it is a potent medication with systemic effects, usually administered through a non-rebreathing mask or a bag mask device. You also have nitrous oxide, which is an analgesic. It may be administered by AMTs to reduce pain. It's administered by inhalation through a mask and has euphoric effects. There are many times I wish that we had nitrous oxide. So your routes of drug administration. A route of administration affects the rate at which the onset of action occurs and may affect the therapeutic response that results from that. So, choice of the route of administration is crucial in determining the suitability of the drug. So, drugs are given by their local or systemic effects, right? Absorption is the process by which medications travel through the body tissues until they reach the bloodstream. So, starting off here, we have enteral drugs. They're administered along any portion of the gastrointestinal tract, uh, oral or per OS, PO, and that which means taken by mouth, and then it enters the bloodstream through the digestive system. Can take as It could take as long as 1 hour for absorption to occur. Uh, Rectal, so per rectum or PR, no AMT medications are administered rectally. Possible exception of D50 if allowed by local protocols. Could you imagine giving D50 PR? Hmm. All right, so. Oh no, it's a yes. It's a yes. So, parenteral drugs are administered through any route other than the gastrointestinal tract. Uh, Intravenous IV injection, which means into the vein, right? For the medications that need to enter the bloodstream immediately, fastest delivery, but cannot be used for all medications. You also have intraosseous or IO into the bone. This reaches the bloodstream through the bone marrow and requires drilling a needle into the bone cortex. It's painful, often reserved for patients who are unresponsive as a result of cardiac arrest or extreme shock. Most commonly used for children who have less available or difficult to access IV sites. Uh, Up next, you have subcutaneous injection, which means beneath the skin. So, like daily insulin injections. You have intramuscular injections, which means into the muscle, right? So, a lot of your drugs like that have the prefix of depot. So, meaning form of deposit into the muscle after being injected. You also have SL or sublingual, which is under the tongue. You have buccal, which is similar to the sublingual route, but it's in the cheek, right? You have transcutaneous or transdermal. We went over that. You have intranasal, which is done through the nose, where you can get an atomizer. It looks like a little triangle cone shaped thing you put on the end of the syringe, whoosh, spray it up there. You do that with Narcan. Inhalation, drugs that can be aerosolized, like your MDIs. Holy cow, that's a lot. I put a whole lot of stuff there. All right, so pharmacokinetics is the study of metabolism and action of drugs. Drug absorption. So absorption is the passage of substance through some surface of the body into body fluids and tissues. There are numerous variables that affect drug absorption, such as the nature of the absorbing surface, blood flow, pH, diffusion, osmosis, filtration. There's a whole bunch. Whole list. Drug distribution is drugs that pass freely and quickly out of the vascular space and into the interstitial fluid. Blood flow to the area determines the amount of drug reaching the particular part of the body. Also, biotransformation, many drugs are inactive when administered and only become active once they have been absorbed and converted into active form into the blood or by a target tissue. And then you have drug elimination, which is the excretion of the drug or waste products from the body of the drug. So it can be done through the kidneys, through the urine. It can be intestines, through feces, lungs, through respiration, salivary glands through sweat, mammary glands through breast milk. So pharmacodynamics is the way in which medication produces the response we intended, also known as mechanism of action, right? It includes factors that may alter the intended response and any side effect or unexpected effects as well. Mechanism of action. So, to produce a desired or a therapeutic effect, a drug must reach appropriate concentrations at the site of action. So, medications cause their action on the body by four mechanisms. They may bind to a receptor site, they may change the physical properties of the cell, they may chemically combine with other chemicals, or they may alter a normal metabolic pathway. Ooh, cow. All right, drug response relationship. So once the medication finds the target tissue, it needs to accumulate to a sufficient concentration to produce its desired effect. The drug response relationship correlates the amount of medication given and response it causes. When administering medication, you need to know the onset of action, the duration of the action, and the termination of the action. The amount of time after the concentration level falls below the minimum level to the time it is eliminated from the body. So, factors influencing the medication interactions. There may be many variables that influence medication interaction. So it's important to know how medications affect the patient and other medications that are previously administered. An interaction between medications occurs whenever the actions of a drug on the body are modified by another chemical substance, such as the ones listed here. So it's important to be aware of potential interactions of medications that are prescribed and those that a patient may be administering. So many patients, especially elderly patients, may take several medications each day, or what we call polypharmacy. The chance of developing an undesired medical interaction increases rapidly with the number of medications that are used. Patients may also take medications that interact with other substances such as food or alcohol. There's usually a warning label on the prescription bottle that indicates the substances that may cause interactions. So some things you may have here is predictable responses. Because of extensive research that goes into developing and testing medication, there's a common knowledge about what a drug will do to a patient, right? You have iatrogenic responses. An example of this would be a urinary tract infection that develops into a patient after insertion of an indwelling catheter. Then you also have unpredictable responses. So like there about the allergy developing, after a person has become sensitized, subsequent exposure to that same substance may result in hypersensitivity. Because the patient is a hypersensitive, the drug activates the immune system, and this may lead to anaphylaxis. So you always need Benadryl on standby, right? So serum sickness, which is a delayed reaction hypersensitivity similar to an allergy, and occurs in a considerable amount of time after a stimulus. It can develop as late as 7 to 14 days after the first exposure to a medication. You also have idiosyncrasy, which is a patient experiences a completely unique response specific to that person and not seen in other patients. So those are pretty peculiar. Something else you can have too is a tolerance. You can have a drug dependence or other drug interactions. You can have drug antagonism. You can have summation effects, which is two drugs that have the same or similar effect and increases the patient response when both are administered to the patient, which would be like an additive effect. Summation, sum of. All right, so you went from, as AMTs, you're constantly at risk for a cognitive error such as choosing the wrong medication or dose, or technical errors such as administering more volume of medication than is intended. So you have to use the 10 rights of medication administration. Was 5, now it's 10. So right patient, right medication, right dose, right route, right time, right documentation and reporting, and then also right assessment, right evaluation, and right patient education. Right. That's a tongue. So you want to make sure that you use a current reliable medication reference source whenever you're administering potentially unfamiliar medications. And technical errors can be avoided by having a partner confirm the volume in a syringe or a weight-based medication calculation. I've seen this in a patient. It's pretty rough. They are not happy. And some of that can be brought by other medications they take, even if they've been taking it for a long time. I forget what the name of the medication is. I'll think of it in a minute. It's for high blood pressure, but I've seen it several times cause this. It starts with an H. HTZ, HZTZ. I'll remember it in a minute. or maybe I won't. Evaluate for a patient medication allergy or hypersensitivity before each medication administration. The Institute for Safe Medications, Medication Practices has developed a list of medications and abbreviations. No. It's some. I'll think of it in a minute. Prone to causing errors. There's a table in your book, 1211. All right, so specific medications that you may administer are going to be oxygen, oral glucose, glucagon, IV dextrose, intravenous fluids or IV fluids, epinephrine, MDI medications like albuterol, nebulized medications such as albuterol, nitroglycerin spray tablets or paste. Man, I ain't seen a paste in a while. Nitrous oxide, naloxone, aspirin, and then there may be some others based on your local protocols also. You may also administer or help administer these medications only under the following conditions. And there's the following conditions right there. Man, I ain't seen paste in a long time. All right. Excuse me. All right. Do we have any questions? That was the end of that one. Thank goodness. For future reference, what? That's your reference. Right. We need the code. Isn't that correct? Woohoo! All right, so the code for tonight is 9876. 9876. 9876. 9876. And that did nothing. 9876. All right. So does anybody have any questions? I see here that AMT Skills Bootcamp A is this weekend on the 7th and 8th. So be working on patient assessment. So make sure that you watch tons of times those patient assessments on YouTube and practice, practice, practice. That's going to be a huge part. And then while you're doing your patient assessment, you can work on your airway skills and your BLS skills and scenarios. That's going to be a part of your patient assessment. Your BLS skills and scenarios, like CPR, stuff like that. And then IV administration is going to come with that. They'll do an IV arm. Okay. Unfortunately, I may be there Sunday, but I know I won't be there Saturday. I may not be there Sunday. I have to check and see because I have drill this weekend. Yay. So I will be at drill this weekend, unfortunately. So I may not be there. I may be there Sunday, or I may be there. I don't know. If I can stretch it, I may be there Saturday evening. From what I'm told, yes. Now, if something changes from there, then they will definitely let you know. I didn't set up the boot camp because I wasn't going to be there. But as far as I know, yes. Well, I'll ask. I'll ask. All right. Um, all right. I'm gonna go ahead and stop recording.